That's putting us on the spot. Primarily because
sorry.
As to why ankylosing vasculitis is a relapsing disease and why it is antigen is not, is quite difficult to understand. But what we know is in ankylosing vasculitis, the neutrophils and the aberrant activation of neutrophils is a constant process. Okay, so you are always seeing the presence of these antigens by these cells to get stimulated. That may be one reason, as opposed to anti-GBM disease, where damage has been done. However much damage is going to happen may not make a huge difference. But saying that, that's not a true possible explanation. But certainly in ankylosing vasculitis, we have seen persistently activated T cells, expressing CD25 or whatever. And what we also know is there is the substrate for activation of T and B cells is constant, so it's never ending. That may be one reason why you may see a constant relapse.
That's also, I looked for that same thing in the lot of stuff, but I couldn't find. One of the things they said is that the regulatory T cells start increasing as the disease goes on, probably abrogate the subsequent response. And then once it is damaged, the antigen challenge comes down. But the antigen antibody probably either there is fibrosis or there is remodeling and the disease process gets longer distance is quite some. So antigen is no longer exposed. So I think that's the reason why. That's what I'm doing. I think I will operate.
Okay, so welcome back. So today we are just going to discuss that what is this jargon of genetics which you see in the reports. And since everybody is now routinely sending genetic reports, it becomes more important to understand why a report is positive, why it is negative, and why it is the in-between thing of uncertain significance. Probably that is the most annoying result a clinician can get when he gets the result from the patient or from the lab. So today we would be talking about the why, when, what, how of a genetic testing, and the thing being that being the one of the smaller organs yet, it is very well classified. So based on the clinical symptoms or your routine testing or some specialized test, you will be very comfortably being able to split your lumped nephrogenetic disorders into different groups. And based on that, it becomes much easier to understand what genes will be involved in the pathology or the etiology of your patient. And they may present either totally non-syndromic, isolated disorders, but they could also present with syndromic, like along with kidneys, they can present with CNS malformation, they can present with liver, lung problems, as well as skeletal dysplasia. So either we are looking at syndromic renal disorders, which are much easier to diagnose because multiple people are seeing. So, किसी के में तो बल्ब जल जाता है that this could be this disorder. But when it is an isolated renal condition, it is totally the responsibility of a nephrologist to understand that what is underlying the disorder. So the most important test as geneticists which we want to portray is that how can you get a clue that we are dealing with a genetic disorder? Is it always inherited? Or could there be conditions in which it is a totally sporadic condition, de novo, and you have no family history whatsoever? Because when you ask the parents, in spite of drawing a 3-generation pedigree, they say, हमारे पूरे खानदान में किसी को ये बीमारी नहीं है, हमारे इस बच्चे को क्यों आई? And the second is, how can we prevent it in the next child? So that is the biggest concern if they have seen a child who is so much into trouble due to recurrent infections or getting dialysis or even needing a transplant, so they would not want another child. So sometimes it is a very easy to detect family tree that if it is autosomal dominant, it is a vertical transition, and every, you might have one person who is affected in each generation. Autosomal recessive usually will be undiagnosed, except that in one horizontal pedigree or a generation, you might have multiple people affected. So you might have 2 or 3 siblings who are affected, and then you say, okay, this could be autosomal recessive. And then X-linked recessive, in which continuously the male members are being affected, but you don't find any female who is so severely affected. In contrast, if you have an X-linked dominant disorders, because the gene is so important for survival that there is very high male lethality, so you might find more females being affected with the disorder and you might not find many males. And then you always have this scenario in which, there are multiple different things and you find one child with Kaku and you have no other history of any other renal condition. So, when we look into carrier screening, it was found that almost 80% of these couples will not have anybody who has a genetic disorder. So there are multiple tests available and that confuses us more because when should we test, with what of these methodologies becomes a concern. So for some simple disorders like you see a child with Down syndrome or you see a child with Turner syndrome with ectopic kidney, a simple karyotype which is cheap also and probably in India it is cheap, outside it has become the last test because now we don't have very good skillful cytogenetics looking into karyotyping, so probably it has become the last test of investigation. Then you might have to go for a test which is known as multiplex ligation probe amplification, which checks the intragenic deletions and duplications. Like for example, commonest would be atypical HUS, where you need to know the deletion duplication in CFHR 3, 4, 5 and other complement factor deficiencies. And then the best, what I would say currently we have the sequencing. So sequencing is basically you are trying to decode your code, and what test you have to send, finally it depends on your phenotype. So as clinicians, our important role is to come to a differential diagnosis as closest as possible depending on whatever the clinical phenotype the child or the patient is presenting with. Unfortunately, they might directly come with a chronic kidney disease and you don't even know the primary cause of that illness. But yet you have to try your best based on whatever available resources to come to at least a differential diagnosis. So the test which we need will depend on the scale of your genomic variation. So whether you want to go for a very low resolution test versus a very, very high resolution test like the next generation sequencing, again it depends on your clinical information. So it is just basically the evolution of technology, and I'm not sure how many of this group, the generation has seen the previous type, but what I remember is when the first mobile came in, I think 1999-2000, the incoming was also 16 rupees. And the first thing was like we used to abuse if we get a wrong number because mere to 16 rupees gaye. But now everything is free, incoming free, outgoing free, you have WhatsApp, you have internet. So with the same technology of telecommunication, you are able to even take a photograph. Similarly, it is just an evolution of technology that from Sanger sequencing, which sequenced, the whole genome project was started with Sanger sequencing, and now we are able to do multiple genes, so it is known as parallel sequencing. 20,000 genes at a time together you are able to sequence. As you can see, the timing has also decreased, the cost per run has decreased, so a test which cost 1.5 lakh in 2008 can now be done in 10,000, right? So this is how technology and the pricing is evolving, and it is becoming easier to send the genetic testing, especially after the Human Genome Project, which took 13 years to sequence your whole genome. Now it takes just 3 to 4 hours, right? And after the telomere to telomere consortium, by March 2022-23, we have the entire genome information with us. So we are approximately not completely 20,000 also, now about 19,000 plus genes which are protein encoding, and we have 3 billion base pairs. So I'll come to that a little later. But out of this 20,000 genes, we have functional evidence of only 8,000 genes. Functional evidence means in animals, in humans, by multiple methods, they have proven that these 8,000 genes are definitely going to cause a human disease. Rest 12,000 are still unknown. We know they are genes, but we still don't know what disorder they are causing. So this is the major reason why we still get reports where in spite of a very good phenotype, we get no likely pathogenic or even a VUS found. So what is a genome? So I'm really coming to the basics. So this is more for the students out there, and probably MBBS, MD would be really fresh in your mind. So any cell which has a nucleus will be useful for doing a genetic testing. So a question, which cell cannot be used? Yeah. RBCs. So RBCs don't have a nucleus. So rest anything and everything in your body can be used to do your genome mapping. So what is a genome? So the entire material in your body which is coming from your parents is the chromosomes. Chromosomes have the genes. Genes are the DNA which is there, and they are just 4 nucleotides. So just like a binary code, 010101 in the computer, we have 4 such ATGCs which are making your code. And the information in this DNA of those 20,000 genes from chromosome 1 to the last chromosome, last nucleotide is known as your genome. So it is a big information database, almost 3 billion base pairs. So again, going back to the past, anybody who has seen these yellow telephone directories, we had one, and every year, the telecommunication department would send a letter that a new one has come up. The names were arranged alphabetically, city-wise, specialty-wise. So you had to go through all those pages and find the address and phone number of your person of interest. Now you consider this is your genome, and I'll come back to it again, why I have taken it as a reference. So the central dogma of life is your DNA. So it is your code which is being given from your parents, and the DNA is transcribed to the RNA, RNA is translated to the protein, and protein is going to give you the function. Right? So you are doing the enzymes, you are doing the hormones, you are doing the basic tests, creatinine, whatever. They are basically proteins, and these proteins are made from your DNA. So to understand the phenome or the phenotype in your patient, you are basically just checking the material or biomarkers which are easily accessible to you. But why they are abnormal, you have to go back to your genome. So that is why we have to know why we need to do sequencing. So to understand, we are all 99.9% safe. So 3 billion base pairs, 99.9% safe. So 0.01% change in one person can make so much of a difference that somebody can become Narendra Modi and somebody can become Sharda. So 0.01% of your 3 billion base pairs, and from that you have to find again one base pair which is going to give why I have got a cardiac disorder or why I have got nephrotic syndrome. So it is not a very easy task, frankly speaking. So but we are trying to make this genotype-phenotype correlation. So how does this sequencing work? So without knowing this sequencing, I will not be able to show how we interpret the report. So again, you are taking any DNA from your body, you are cutting it off because it's so huge, so large. You are just scissoring it off, chop, putting it into small base pairs, 100 to 50. That is short read sequencing, what we call it. And then you separate it out. So you cannot sequence a double stranded DNA. You have to make it into a single stranded DNA, and then you use the process PCR. So everybody is aware of PCR. I don't want to go into details, but you are copying it again and again and again. So exponentially from one single strand of DNA, you are now making billions of strands, and then you are again sequencing it from one end to other. So the technology is quite complicated, but the thing is now we have to again arrange that according to some reference sequence which is available on the public database. So we don't even know whose genome is that, but we are considering him or her to be an extremely normal person with no disorder. So now coming back to those yellow books. So yellow books, you are just shredding it off and then trying to align it all together. And you can understand at what level you can have the properties. Right? It's not very easy to. So there will be deletions, there will be duplications, there will be missense, there will be one word chopped off, there could be one letter chopped off. But again, this is what sequencing does. So you chop off your genome and then you again realign it. So this is how the NGS workflow works. So you are putting a drop of blood or a drop of DNA, and then your machine is doing everything, and then this red, yellow, green color fluorescent dyes come up. And then it is arranged into a file, which is the raw data, and it is the role of the bioinformatics to make sense of this raw data, which even I cannot understand, and then we are given the report. So this is a very complex procedure. So we think that, okay, we have data, now the bioinformaticians have to start. But it is really a very difficult task, and it is not finding a needle in a haystack, it is finding a needle in a needle stack. You just need to find a red needle amongst all the other, pink, purple type of same shaded needle. So this, and more importantly, is we always feel that more data means more information, more knowledge, but it is not always so. So that's why we have to choose that which is the best test, where we can get adequate data, adequate information, but it should be valid also, and it should be implicated for your patient. You don't want unnecessary information coming out for which you cannot do anything for the patient. So what we suggested was, like, let us do gene panels. You have a child with nephrotic syndrome. After following up, after giving steroids, they're not responding, so you start suspecting it is steroid resistant. So now steroid resistant nephrotic syndrome, and according to the literature, initially you had just 12 genes, then came up to 24. I think now there may be more than 50, 60, 65 genes which are implicated in steroid resistant nephrotic syndrome. So you do a gene panel. So this becomes important because now the analyst, the lab, and you yourself are just focusing on those limited 60 genes and finding out. You are not bothered whether the patient has G6PD, you are not bothered whether the patient has some BRCA1 variant, but you are just focusing on your genetic diagnosis. Beyond that, if you want to go, you can go for the whole exome. Now the exome is just 1% of your entire genome, just 1%. So obviously the costing will also be just 1% of your whole genome. And in that, what we do is we just clip off the exons of the genes. So if you have 20,000 genes, you just clip off those 1% exons of all the 20,000 genes and focus on them and leave aside the intron. 85% of the disease causing genes are focused in the exon. So probably you can say, okay, 80% we might get some diagnosis if we just focus on the exon. So currently this is the best test which we can offer on a diagnostic front for your patient, irrespective whatever etiology they have, but they should be focusing on the phenotype which you provide. So based on that, you will be getting a report. So either you get the information which is as small as a floppy disk. Again, many of you must not even have seen a floppy disk, but yes, floppy disk, then the CD, and then the drive, but now it is the cloud. So more data cannot be stored on any machine in a lab because it requires a lot of space, so it's not all on the clouds. But the more information you need, the more accuracy you need, you have to pay higher for it. So to compensate for all that, we are focusing on whole exome sequencing currently. So what are these variants? So if we are different, then what is this difference? We are same but different. So these are the variants which can be changes in your genes. They can be just a single nucleotide which is changed, so it is known as single nucleotide variant, or it could be a large deletion duplication which is known as a copy number variant. So this is a small prototype of a gene. A gene can be just one exon, gene can be 80 exon, gene can be 113, 140 exon. So depending on the size of the exon, you can have multiple types of variations in your exonic data. So this is what your ATGC looks like, indecipherable, just based on 4 ATGC nucleotides. And now again going back to your biochemistry, each codon is important. Codon is a pairing of 3 of these nucleotides, and every nucleotide, so this is a permutation combination of 4 letters ATGC. We have 20 different amino acids, but we have 64 codons. So obviously, to compensate, there will be more than one codon which will be making the same type of a protein. So that is known as a synonymous change. So in spite of having a change in one of these letters, the final amino acid is same, so it will not cause a disease. But if this change is such that it causes a stop codon, or it is a change which causes a nonsense codon, then probably the protein will not be made further. So so this is how it would look if your single variant also is changed, like in the second one. So this A is deleted, right? But then the whole codon changes. So instead of AAG, it has now become AGC, and so the lysine has changed to serine. So this is how it can cause a disease. But sometimes there is like the lysine has changed to methionine, and we don't know whether it will cause a major change in your final protein structure or not. So there are certain variations which we are sure will cause a disease, but there are still some which we are not very certain about without doing a functional study. So easy way out is just understanding by words and letters. So this is the grammatical mistake which can happen when you are trying to decode. So a very simple sentence: the cat saw the rat, right? The cat sat the rat. So the words change. It doesn't make any sentence, but there is just one change. But if the cat saw the bat, it is not making any grammatical change, but it is just that the sentence has meaning, but still it is different. Nonsense, entire codon after that is not there, so amino acid is not there, so the protein will not be made. And then there are silent in which the C is still a C, but the meaning is not there. We don't have a dictionary word for KAT. And then there are in-frame deletions and out-of-frame deletions. So these are the major types of variations which you will see in the report. And then based on that, you can see why it is classified as significant or not. So these are the ACMG guidelines. So any genetist, any person who is going to interpret the reports should read these ACMG guidelines. From 2015, they have gone many changes, and the latest would be coming in 2024. That's what they said. But probably in a month or so, the newer will come out. But it has taken like almost 10 years to keep improving, decreasing the type of variants of uncertain significance, because of these VUSs, we are not able to take any action. So they are considered unactionable variants. So how can we decrease these uncertainties? So many classifications are being used. So what are these levels of evidence? This also you will always find in your report. Whichever lab does it, right, they have to give you the data that how many times it has been reported in a general public database, what is the computational evidence, what is the functional evidence for that variant, what is the segregation means. Segregation means in the same family, if affected people are having the same variant and unaffected people are not having the same variant, then it may make a difference. So paternity issue is a big thing. So before saying that it is de novo, we have to test the biological parents, and then only we can call it de novo. And then there are many other databases of each and every disorder. So for hemophilia, there is a database. For thalassemia, there is a database. So we have to go to those databases and understand whether our variant which we have found is significant or not. But ultimately, it comes down to your phenotypic correlation. So in spite of being a very good variant, if it does not match your phenotype, then it is of no use to the family. So the final report would look like this, that you have the gene, how much it is covered, whether it is a missense variant or a nonsense variant or a frame shift variant. Then it will have the details of the depth, means how many times it has been read, and the transcript, whether it is in the protein database or not, and whether it has been reported. So many things go out into filtration of one single variant. So the sequencing may not take time, but the analysis and interpretation definitely takes time and experts. So that is what gives the timing that, okay, if you can sequence in 3 hours, why can't you give us the report in 2 days? So that analysis, interpretation after so many billions of, if you want one single variant, then definitely it takes a lot of time. Right. So coming to renal diseases now, again, I would say it is easy if you are able to differentiate it at what segment of the kidney we want to focus on, and depending on that, we can choose the gene. This is a very old paper, almost 10 years old, but I still like it because it gives a visible impression of how there is a correlation between genes. So there is lot of phenotypic and genetic heterogeneity. So same gene may cause multiple phenotypes, right? And one gene itself can cause multiple phenotypes, and one phenotype means just nephrotic syndrome can be caused due to multiple genes. For example, Alport syndrome, there are just 3 or 4 genes implicated, but it will cause autosomal dominant, it can cause autosomal recessive, it can cause X-linked dominant, it can cause digenic inheritance. So there is so much of genetic heterogeneity. So without doing the appropriate test, you will not still be able to confirm whether your variant is really causing Alport syndrome or something else. A few examples I would like to go, some may be very simple, like a 11-year-old male child antenatally showed enlarged kidney. So postnatally, he was under follow-up with a nephrologist. multiple cysts were seen, and the father and grandmother have diabetes. Now you will say, how is this correlated, right? But the referral diagnosis was ADPKD or ARPKD because antenatally the cysts were seen. Dr. Aditi is saying no, but you're right. So this is what experience tells. So now the importance of taking history. If we don't take even this history, then probably the report interpretation might not be so simple. So the name itself is saying renal cyst and diabetes syndrome. So the HNF1B gene, now advantage for this whole family. So retrogradely you have handled the whole family. The father and the grandmother who have diabetes now will be under surveillance for polycystic kidneys. They will be evaluated. They might be asymptomatic till now, but they can get it anywhere, right? And similarly, the young child who is just 11 years old, we have to keep him in surveillance for developing diabetes. So indirectly, you are helping both. So now the report itself shows you the gene name. It says the transcript. It shows the exon. It shows the type of variant. So this is the termination variant. C dot means the location of the DNA code. So it is the codon 8 to 6. And the change is C has changed to T. And then you have the protein, this is T dot, where arginine at 276 position is terminated. So after that there is no protein formation. And then the classification is pathogenic firstly because it is a termination variant. And secondly, possibly it has been already reported in literature. So this is the OMIM phenotype which usually the labs put it in the report, and the inheritance pattern. So autosomal dominant means at least one allele should have the variant. Now we have to, and the family history also suggested the same, that the grandmother must have passed to the father and the father has passed to the son. So this is almost confirmatory with everything what we were looking at. So here everybody is happy, including the clinician, the lab and the patient. Now a retrograde diagnosis is a reverse phenotype. Here a clear-cut diagnosis of nephrotic syndrome, elder sister died of SRNS, and what we get is a complement hyperactivation and idiopathic thrombosis. So the first impression is no, it's not matching. Because as a clinician, we must have already looked at a differential diagnosis and it is not matching. But here there are two siblings affected. This is a autosomal recessive condition. You have found a homozygous variant. Homozygous means the same variant is present on both the alleles. So this is homozygous and it is a termination variant. So variant is very good. But is it really matching your phenotype? So you may have to evaluate further for protein losing enteropathy, or because the elder sister was not tested, we don't know. If we do it in the parents, they might turn out to be carriers. But the important thing being that in OMIM, there is just this phenotype written. So this is by AI generation, the phenotype is taken up. If you go back to OMIM, it has not been updated since 2017, right? So you have to go back to literature, just look at the gene, just look any other information has been found. So there are 3 or 4 papers which say that this gene is associated with nephrotic syndrome kidney disease. So literature evaluation at your end will also help the lab to reclassify the variant, or you can work up further and confirm that what your clinical diagnosis was good enough. Here again a congenital nephrotic syndrome based on all the clinical findings, and you are getting pathogenic variants in NPHS1, which is probably one of the most common genes involved with congenital nephrotic syndrome. So there is a very good genotype-phenotype code match and everything is fine. So this is autosomal recessive due to compound repression. Now there are 2 different variants. So one has to come from the father and one has to come from the mother. In such cases, always do the parental testing just to confirm. Even though the exons are very far off, there are chances that they might be coming together from one of the parents and there might be something different in the mother. So I'm not taking this example, but it is always better to do the parental testing in autosomal recessive condition. So here again there is a termination variant and this is a missense variant, but it's pathogenic probably because it must have been reported and there must be good functional evidences. So here antenatal detection of cysts, again paternal grandmother also has some renal disorders and the suspected was autosomal recessive, and some clinicians are so strongly suspecting that they even write the gene name that we want to focus on this gene. Here again what we found is two different variants in PKD1. Now, PKD1 causes autosomal dominant type of polycystic kidney disease. So can you explain this? Dr. Aditi will say yes because she knows about it. So, in spite of being an autosomal dominant, you can get two variants, and again, the literature helps you out that biallelic PKD1 mutation can cause much more severe disorders similar to an autosomal recessive condition. And there is also papers which say PKD1 and PKD2, so that becomes digenic, two different genes, but a single variant from each of these genes can also cause a severe type of ADPKD type of a condition. And sometimes we may get something which is beyond the common. So you are suspecting ADPKD. There are 2 or 3 genes involved, PKD1, PKD2. But now as literature advances, we know that there are much more genes which can cause a similar phenotype. Again, a +1, splice1 variant. It is likely pathogenic, but the phenotype is liver disease with or without kidney disease. So here the primary should be liver, but the patient has no liver finding, or either we have not looked at it, or because the test has been requested by a nephrologist, probably the liver findings were not involved in what we got. So here it is a commonly diagnosed disorder, but the variant is very rare and the gene is also very rare. In this it is said that only 28 to 30% will develop kidney cyst, but the characteristic feature is the liver cyst. So we have to evaluate this patient. And if you look at again OMIM and you find polycystic kidney disease, this gene is not even in the list. So if we try to choose a panel for ADPKD, this gene might not have been evaluated. But if we look at polycystic liver disease, this gene is there. So how do we go about it? Send a whole exome. So here, this is that renal cysts are usually incidental findings and they may not cause much problem. So the family can be evaluated accordingly. Sometimes it is a much bigger thing. So are there two different disorders in the same person? Can we explain that? The patient also has polycystic kidney disease and also has tuberous sclerosis. It could be, and it could be because tuberous sclerosis can cause polycystic kidney disease. You send for tuberous sclerosis, it might turn out to be negative. But when you do a whole exome sequencing with CNV calling, where we check even the copy number variants, then something like this, which is a contiguous gene syndrome, and it is a very known thing that along it is the same chromosome. So there is a big deletion which is involving PKD1 gene and the tuberous sclerosis 2 gene. So when they are deleted together, it will cause a phenotype which will have a dual diagnosis. The advantage being that now this entire family needs to be evaluated not only for polycystic kidney disease but multiple other systemic disorders. And then yes, you have one of those cases that in spite of doing everything and a very clear-cut diagnosis, you will not get anything, or you may have something like Alport syndrome, you may not get anything. So what is the reason? Why are these VOSs? Why are these negative reports? So again, we still focus that probably we have not sent the right test. There could be something else going on. Technical issues, PKD1 exon 1 is never covered in NGS panels because it is a very highly complex region. So your region or your gene of interest, how well it is covered in their panel or their exome need to be discussed. Pseudogenes are there in multiple genes. There are multiple rearrangement genes which will not be covered by sequencing of the short reads, but yes, long read sequencing or whole genome sequencing is coming up in a big way. So probably these technical limitations can be covered. And again, a very wonderful paper, very well worked up. I would feel that how they have checked for importance of extrarenal features, the subtype of the kidney, family history, and age of onset, and they have tried to evaluate the diagnostic yield. So as you can see, the diagnostic yield can be as low as 3.3%. to 100% in tubular disorders. But in other conditions, it may not be very high. And that also depends on your age of onset. Because earlier the age of onset, your phenotype is also different and the types of genes involved are also different. So your pickup rate, as you can say, the best would be in tubular disorders in adult onset or what are known as later presenting disorders. So this is again, you can see that they have done genome sequencing, whole exome sequencing, microarray, but the advantage of reading the papers is they usually use trials, because your de novo or your segregation becomes very easy. Many of the variants of uncertain significance are excluded once you send the trials. Trials means mother, father and the affected child. Definitely the costing goes up, but your solutions will be better. So yes, these are the routine questions which a clinician or the parent would ask, that आपने तो दे दिया, अब हम करें क्या इसका, right? What should we do? मतलब या तो डालो ही मत, डालते नहीं है वो दूसरी लैब में जाता है, उन लोग कुछ VOS देते हैं, देन क्या आपने क्यों नहीं डाला, आपने मिस किया. So many things keep on going in a vicious circle. So the general consensus is we are giving it to you. You let us know what you want to do further. We can do reanalysis based on extra phenotypes which you can give, but caveat is don't take any management, treatment, prenatal diagnosis decision based on a variant of uncertain significance. As the data is increasing, it has been found that the VOSs are usually downgraded to benign likely benign rather than upgraded to pathogenic likely. So as the information is increasing, as the databases are increasing, we have found that we should not be taking any decisions which are irreversible if you have a VOS in your report. Try a little more to get it all worked out. So many efforts can be done. Functional studies may not be possible in all patients, but yes, reevaluate the patient. Find one more extra clue which can help. You try additional laboratory testing. You can again understand the mode of inheritance, whether it is an autosomal recessive condition and you have just found one heterozygous variant. Is that the reason why it is VOS? Then try to find a second variant, or try to find literature in which they say that autosomal recessive heterozygous might also have some findings. So, and then you do the familial segregation. Segregation again, it is not only doing the parents and the affected. Doing one more unaffected person will also help to change the classification. So this is MLPA. So if you have not found a second variant, or if you have found a none report and you find that your disorders are anything among these, then you may have to opt for a test which is known as MLPA, in which they look at genetic or intragenic deletion duplication, which will not be covered by a whole exome sequencing until unless they have too much of a data where they are doing copy number variants. More than 2 exons, it is easily validated by NGS, but 1 or 2 exon level deletion duplications will not be very well validated by NGS. So there are many other syndromes or disorders for which you may have to opt for MLPA if your sequencing is negative. So this is what a segregation, everything fits: recurrent nephropathy, family history, uncle and a sibling, and you have got homozygous variant, but the same variant was not present in the other affected sibling. So this indirectly makes it a useless variant, or we can definitely confidently ignore it. So coming to the only one, you have to have a very good clinical correlation. You have to have literature search and update, come to CMEs like this and meet experts who have much more experience with their data and how deep they go to get the diagnosis. That is very important. Yes, family testing definitely helps. A little information to the lab, a little discussion. No lab will refuse doing a trio. If you really want to do it free, it can be done free. It can be done at a discounted rate. It can be done at the research. But try to do that additional workup, and definitely collaboration and data sharing. If each segment, like nephrology, neurology, hemato-oncology, they have their own society at city level, national level, international level, if they can have their databases with the functional evidence, then probably the incidence of VOSs will definitely go down. And to summarize, it is like we have to order the appropriate test. Receiving the results is more complicated because we want to familiarize ourselves with the contents of the report. Clinical validity and utility. Just getting a positive report because you have committed to the patient that genetic test is going to give you all the answers should not be a reason why you should get something in your report. How much useful it will be for the patient is also important, and whether whatever we get after that we are going to do anything for the patient is also. And most importantly, ethical, medical, legal issues are coming up in a big way. Refusing a test, not offering a test, or doing unnecessary test, everything is going to come up like a medical legal action nowadays. So pre and post test genetic counseling. So you don't give your hopes up that everything will be resolved after you do a genetic testing. You just tell them that as per current literature, the pickup rate for this condition which you have is about 40%. So the patient doesn't have that, oh, abhi main report 20,000 rupiya kharch kiya, ab mere ko to report positive chahiye. So that hope of getting a positive report as soon as you give more money, that information should be totally not given to the patient. So yes, counseling is very important, and we have to keep learning, unlearning and relearning, because being in genetics, we have learned that 1 plus 1 is never 2. Thank you so much.
Thank you, Dr. Sharda, for making a complex topic, or at least attempting to help us understand it. Our respect for geneticists has grown up by leaps and bounds, and I'm sure some of the bold people sitting in the audience may have a few questions.
And I would definitely want Dr. Aditi to answer those questions. Yes.
What is the turnaround time average of single symptoms, MLPA and clinical response? Okay. So sometimes we send together and they give the report together. But what is the, if we send, as you said, specific test, what is the cost?
So Sanger currently, as per global, nobody is sending for individual genes. They are just for doing a variant which is found. If you want to do familial studies, you want to do it in multiple members, you do Sanger. It might take minimum of 10 to 14 days. Because we have to order the primers need to be validated. If it is a known, like HBV, if you want HBV, we can give you in 7 days, because we already have the primers validated. But if it is a new gene, new variant, the transcripts are different. So NGS may give you a different transcript, but when the person is giving the order for the primer, the person who sends the primer might be using a different transcript. So yes, we need to validate on positive and negative reports, and then we can. So 14 days I will say. For clinical exome, which we currently are not doing it, but clinical exome or board exome which we say, then it can take anywhere between 7 days to 20 days. So we have options of rapid exome and ultra fast exome. So if patient is in critical condition and they want to take a decision, yes, you will have to pay extra, but you can get a result in 7 days because it will be prioritized. But 28 days, it is coming down to 21 days. Few people can do give it even in 18 days, but we keep a tag of 20 days.
Costing?
So for Sanger, it was 5,000 for a single variant. We are doing the same variant by NGS, same cost, 5,000. If you send a couple, then probably, like we had a very good US resolution program in which in 1,500 per person we used to do the family per person testing. But it didn't work out very well, so we have stopped it. But MLPA would take anywhere between 8 to 10,000, and again it is turnaround time is 20 days. Thank you.